Good morning, everyone. We are just about ready to begin. Please be reminded that we are going to be going on Facebook Live simultaneously. So there will be those logged in through the Zoom meeting. And then, of course, there will be those watching via our Facebook group channel. I am inviting everyone to add their questions in the comment box. We will address questions at the end unless, and of course, there is something that needs to be addressed more expediently. I'm getting everything set up for our Facebook Live, and we'll begin there. There we go. All right. I'll do one more introduction as well. Okay. One second, just confirming that we are up and live. Perfect. All right. Well, thank you everyone for joining us today. This is our second session of SickleSMARTSummer. Thank you for taking the time out of your weekend. We have an incredible show coming up for you. I guess I should show my face. We have an incredible 2-hour session coming up for you. I want to give a little bit of background of SickleSMARTSummer. Typically in the month of April, Sickle Cell Foundation of Minnesota, in partnership with the National Minority Health Awareness Month in April, is typically when we do our sickle cell management of sickle cell symposium. Because of COVID, we were unable to do that this year, and so what we did is we turned that into an entire summer of education, and we named that SickleSMARTSummer. And whether it's the summer, winter, fall, or spring, you always want to be sickle smart, and it's very important to know your disease so that you can get the outcomes and you can work with your team as the captain of your ship to be able to do well and live well with sickle cell. So without further ado, I want to make sure that we introduce our speakers for today. We have 3 wonderful speakers. Our first speaker is Dr. David Wood, and he is a researcher at the University of Minnesota. Last year, he presented at our symposium, and it was one of the most amazing presentations that one could ever watch. Watching an actual red blood cell change shape before our eyes into a sickled cell, and it was just, it was incredible. And so we've asked him to come back again, and he's going to be sharing research tools for the sickle cell community and what they're doing in research. We also have Dr. Stephen Nelson, who is a physician at Children's Hospitals and Clinics of Minnesota, which is a pediatric center that cares for over 90% of the pediatric sickle cell population in the state of Minnesota. I have my community hat on, so I can say this, that I do have a bias in my heart and in my head for Dr. Stephen Nelson. He was my son's doctor, but outside of just being my son's doctor and being an incredible doctor, he's an incredible human being, and he does so much around sickle cell and the community, and around bias in healthcare that exists, and so though that's not his topic today, I am absolutely sure that he will make statements that allude to exactly what we are facing and what solutions look like as well. So and then last but not least, we have Dr. Jed Gorlin. He wears multiple hats as well, but in one of his capacities, he is the medical director at Memorial Blood Centers, and he is an expert in transfusion medicine, and he will be presenting on sickle cell disease and transfusions. So without further ado, we are going to turn it over to Dr. David Wood. Dr. Wood, you're on.
All right, sorry about that. I had to unmute myself before I started the presentation for some reason. Okay. Well, thanks for having me, Ray. It's really a great opportunity. Obviously, it's sad to not be with everyone in person this year, but it's still obviously great to get to talk to this community that I care so much about, but that I don't get to interact with in the same way that, say, Dr. Nelson does. And so it's always a wonderful opportunity for me to actually get to talk to you guys a little bit about what I think about day to day, and how I think about this disease, and what what motivates me and what my lab is doing at the university to try to make steps towards making your lives better, living and easier to live with this disease. So let me just start. Please don't read all this text. It's up here so that folks can read it later on the slides if they want to. It's just a little blurb about me, so you know who I am. But what you need to know is that I'm an associate professor in biomedical engineering at the University of Minnesota. I've been there now about 8 years, just shy of 8 years. And I've been working on sickle cell disease since about 2008, so a little over a decade now. And I initially got into sickle cell because all of my education, my degrees are all in physics. And I originally got into sickle cell because someone described it to me and sort of the molecular origins of the disease. And I just found it so fascinating, just intellectually. And I still do a decade later. But in addition to that, I would say over the last decade, not only do I find it intellectually fascinating, but I've gotten to know providers and patients. And I think my personal passion for this disease have just really grown over the last decade. And so I'm even more committed than I've ever been to making sure that the research we do actually has an impact on people's lives. Now, that's a slow process, getting research to the clinic, but we're trying. So anyway, so that's just who I am. And then I also want to introduce my lab. These are the people who actually do the work. So this is just a fun picture of us having our maybe our first virtual happy hour after the coronavirus shutdown, and just a way for us to get together and talk to each other. But what I want to highlight for you here, other than all the great smiling faces here, is on the left is just, so this is my current lab members, and I just want you to see the number of people who are actually working on sickle cell disease. So everybody in blue here is actually working on sickle cell disease. So it's over half my lab actually focuses specifically on sickle cell disease. So it is a major, major part of my research program, and something that I'm very committed to. And also, if you look at our collaborators, and actually I realized Steve is not on here, which is too bad, so he should be on here as well. So we've got a number of collaborators, all also, many of whom also are in sickle cell disease. So it is a real emphasis for us. And I think one of the things that I'm proud of in terms of what I've done in this research space is not just my own work, but also the people that I have brought into this disease who didn't work on it before I sort of introduced them to it. So for instance, Dave Odie and Jonathan Sachs, and then also Melissa Kemp here at Georgia Tech, these are people who didn't know anything about sickle cell disease until I told them about it. And I saw them and their expertise, and I said, you have something to offer to this field, and I want you to be part of this, research effort, because I think you can help me and our research make more of an impact. And so that's been awesome. And I think, the more people we can bring into this community, the better. Okay, so that's just a brief introduction. So here's what I want to do today in the sort of half hour that Ray has given me very generously. So I want to do a little bit of a redux of what I did last year and sort of show you where the disease comes from and actually show it to you. And hopefully people will enjoy that. And then I'm going to talk about a couple of things that are going on in my lab that I think are of interest. So one is a new way to sort of evaluate clinical treatments, a new potential clinical tool that I think could be exciting, or a tool for use in therapeutic development. And then I want to talk about a new way to develop new therapies that we're working on that I think is pretty exciting and has already produced some pretty cool results. So I'm going to just touch on this here at the end. So let's start with a brief review of the disease. So I think many of you have some idea where this comes from at this point, probably gotten lots of background on it. So the idea is there's a single point mutation. That means those long, when you see the DNA molecules with all the little letters from your high school biology, it's one letter being flipped, right? That one letter flip causes one amino acid change in the beta globin subunit of the hemoglobin molecule. And that is the whole origin of the disease. It all comes right from there. That one letter flip on that long kilobase long DNA molecule, tens of thousands of letters, one of them changes, that's enough to cause this whole thing. And, you know, the basic thing is normal hemoglobin and oxygenated sickle hemoglobin, they exist in solution. They just float around inside the red blood cells and they bind and unbind oxygen as they're passing through the vasculature, through the blood vessels. And then when the sickle hemoglobin deoxygenates, so when it goes through your tissues and the red blood cells unload oxygen, which is what they're supposed to do, they're delivering oxygen to the tissues of your body so that they can function, then that sickle hemoglobin actually starts to polymerize. So that means they aggregate. The molecules start to come together and they form these fibers, okay? So that's the molecular basis for the disease. So, and then when you go up to what's happening at the actual red blood cells, so these are the most popular cell in your blood. There's billions of them per milliliter of blood. So just tons of these things in there. And their purpose is to carry oxygen throughout your body. The problem here is whenever this normal soluble hemoglobin becomes polymerized in your tissues, then of course those polymers actually end up changing the shape and the mechanical properties of those red blood cells. So suddenly these cells that are supposed to be floppy and squishable, they become stiff, right? And that's bad because when they're trying to get through the vasculature, right? Hold on, I need to, it's very interesting with this laser pointer. You can't interact with Zoom when you have the laser pointer on. Okay, so when you're in the vasculature, so these blood cells are supposed to be able to just squish and flow and kind of go wherever they want to go and squeeze past each other. But then suddenly they become rigid and stiff, and that means now they can't kind of squeeze past each other and turns and constrictions, and so they can actually just completely clog up the vasculature. And that's called a vaso-occlusion. And of course, when it happens, then you can have crisis, and that's, you know, often the reason people come to the hospital. But I think more problematically, this is happening all over the body, all the time, and so there's lots of chronic effects of this happening, and that's the sort of chronic inflammatory state, frequent pain, immune problems, susceptibility to infection, et cetera, chronic organ damage that we all know all too well, sadly. And of course, the picture I painted is a fairly simple one here of this sort of biophysical process. And it's more complicated than that. The endothelium, these cells that line the blood vessels, are involved. The immune cells that are floating around in your blood are involved. So there's lots of things that happen that are involved here. But just as a basis to understand at least where the disease comes from, this picture isn't too terribly bad. Now, you guys probably all know this picture. You've all seen it in some basic education or from the NIH, or maybe Dr. Nelson explained it to folks. But I think it's seeing is believing. And so a part of what my lab does is actually develop tools so that you can see what's happening here and here and here, and actually just watch it happen. And so that's what I want to do now. I just want to show it to you. So this is what's happening with those molecules that polymerize. So this idea is that when you deoxygenate these hemoglobin molecules, they polymerize into these fibers. And what I'm going to show you here on the what I'm going to show you here on the right in this movie is those fibers actually forming. So this is not inside a red blood cell. This is reconstituted hemoglobin, sickle hemoglobin, that we're taking the oxygen away from and we're just imaging it on a microscope. And so here's what that looks like. So these are the fibers forming. Those are actually sickle hemoglobin fibers. There and there and there and there. You can see them coming up and they look like a bed of snakes, but they're actually not. They're not anything big at all. In fact, this fiber right here is about 22 nanometers across. So that's a human hair is about 100 microns. So this is about a 10,000th of the width of a human hair, just to give you a perspective. So we're looking at something that's extremely tiny here, right? But has such a big effect. And you can see that here, right? When all of these fibers form and this big, you can see this guy forming, but then when this really big bundle starts forming down here, then you understand exactly where the disease comes from. This is the problem. It's this big gel or mat of fibers that forms inside the red blood cell that ultimately changes its deformability, its mechanical properties that make it not able to flow through the blood vessels. Okay, so that's what's happening at the molecular scale. Okay, so then what happens with the cells? So we said, you know, they turn into sickle shape. So these are human red blood cells. So we've taken these from a sample that you know, a sickle cell patient has very kindly donated to us. And then we, you know, take the oxygen away and then we watch what happens. And there it is. So that's exactly what you're seeing in this picture here. That's it happening right here, right in front of your eyes. So those cells are turning into the sickle shape as that polymer forms inside of them under the deoxygenation, right? So, and, you know, it's also worth just noting here that, you know, while they don't all take on exactly what you would think of as a sickle shape, they're changing shape and they're also becoming stiffer. And so I just want to emphasize that point again. It's not just the shape change, not just the sickle shape that's problematic. It's also, it's really about the fact that they're not deformable in the way that they should be. Okay. All right. So that's at the cellular scale. And so then if we move up to the blood, this idea of vaso-occlusion, which everybody has heard about, the crisis that happens that you have to go to the hospital for. So the question is, can we look at that? And we can do that too. So what we do is we take whole blood and we put it into a microchip. So it looks like this. So basically this tube here, you flow the blood in and it flows through here. And these things here that you're seeing on top are basically channels that we control gas in. And that gas mixture, the idea is that we can pull the oxygen out of the blood while it's flowing through this device. And then when we pull the oxygen out, we can see what happens to the blood as it's flowing. Okay, so I'm going to show you a video of that. So again, this is blood that's from a sickle cell individual, very kindly donated their blood to us. We have lots of very generous people, many of them at Children's Hospital, who donate their blood to us so that we can do this research and perform these studies. And so I'm going to show you this video of blood flowing in this device. So just to give you a scale here, you know, these are individual red blood cells that you're seeing. So this channel here, this width is about 20 microns across. So that's about 1/5 of the width of a human hair. So this is pretty small. It's about the size of a large capillary in the, or a very small artery in your body. So sort of right at that transition between a big blood vessel and the very smallest blood vessels. It's just above the size of the smallest blood vessels. So this is a pretty good representation of what might be going on inside the body. So this is normal blood flow. This is what it looks like, right? Everything's oxygenated. The cells are squeezing and they're deforming and they're doing what they should, and the blood just flows along very nicely. But if we take the oxygen out, things start to change. So this is a little bit less oxygen, and you can already see the cells are looking a little bit different now, looking a little bit stiffer, starting to show some changes in shape. And what you're going to see is that they're going to keep slowing down keep taking more and more oxygen out of them. And eventually you have all of this polymer formed inside of all of these cells. And now you can really see them very clearly, super rigid. They've clearly changed shape, right? They're clearly bouncing past, they're not able to move past each other. They're sort of jostling against each other. It looks more like a solid than like fluid cells. And they're coming very nearly to a full stop, right? And again, the idea is to give you an idea of what's happening inside the body when we talk about vasoocclusion. We talk about this idea of these cells becoming stiff and causing a jam inside of the blood vessels. And this is the best picture that we have of what that looks like. And that's us actually doing this imaging on whole blood ourselves. And you can put the oxygen back in, which you're going to see now, and the polymers actually melt. They fall apart. And then the red blood cells become flexible again, and then they'll just start flowing normally again. So that's sort of the amazing thing about this, is that what I'm showing you is a process that's really just very physical in nature. So it's not magic. You know, we take the oxygen away, this polymer forms, it changes the properties of the red blood cells, it makes the blood jam. We put the oxygen back in, those polymers fall apart, the red blood cells become flexible again, and they flow totally normally again. It's a very physical process. And, you know, like I alluded to earlier, the disease is more complicated than that, right? There are other biological factors that influence this process. But just to give you a sense of what's actually going on, or what the basis for this is, that's what I hope that this shows you. Okay, so that's just a brief review of the disease and where it comes from. And now I'm going to switch gears and talk a little bit about some of the active work going on in my lab. And so I want to talk a little bit about gene therapy and hydroxyurea, because those are two pretty hot topics. I think hydroxyurea obviously has been around for a long time now, but many more people are using it than they were a decade ago. And then gene therapy is obviously something that people are extremely excited about. And so let me just talk you through a little bit of that. So the idea with both of these therapies is that you want to make basically the hematopoietic stem cells. So those are the cells that actually eventually make red blood cells. So they will divide and differentiate and turn into red blood cells eventually. And you want them to make something other than sickle hemoglobin. So the idea is that if they can make fetal hemoglobin, which is the most common one that we think about, certainly for hydroxyurea, or we can get them to make normal adult hemoglobin, so basically sickle hemoglobin without the mutation, then the result of that inside of the red blood cell is that when you deoxygenate, it's harder for the sickle hemoglobin to polymerize in the presence of this other hemoglobin species, right? So the idea is that when you're untreated, of course, your red blood cells have 100% of the sickle hemoglobin. When you use hydroxyurea, maybe we can get 25% fetal hemoglobin inside the red blood cells, and that may be enough for the cells to sort of escape the capillaries without polymerizing at all. And so you can sort of avoid this vasoocclusion, okay? It's just a probability thing. So it's not cut and dry completely. Doesn't mean none of the cells will polymerize. It doesn't mean all the cells will stay good, but we just need a certain critical mass for this to work. And the same thing is true for gene therapy. It works differently. We're actually changing the genetics. So we're changing the actual genes inside the stem cells themselves, but the idea is the same. We want them to make some other kind of hemoglobin, so fetal hemoglobin or hemoglobin A, adult hemoglobin, instead of HbS, so that we can prevent that polymerization that we're talking about. So the trick with it is, as everyone I think probably knows at this point, is that in fact, hydroxyurea has a fair bit of variability in terms of its clinical application. So in general, I think it's great, and I'm glad more people are using it because it's a good therapy. But we do know that there's a variance in how people respond to it, and the question is, why is that? So, you know, for decades now, I think the proposed hypothesis has been that, well, it's all really about the distribution of the fetal hemoglobin inside of the red blood cells. So this is from a paper that was published earlier this year, not from my lab, where they use an assay that actually measures the amount of fetal hemoglobin in each individual red blood cell in a population of blood cells in a blood sample, and then kind of see how it's distributed amongst the red blood cells. And so what you see here, so this is 12 patients, and then green are supposed to be the cells with a lot of fetal hemoglobin. You can see that it's not the same for everybody, right? So here's somebody that has mostly cells with fetal hemoglobin, so that's most. Then you have here a patient who most of their cells don't have any fetal hemoglobin at all. And then you have some patients that have, quite a mixture of the two, and then some that have sort of half and half. And so the idea is that the way that fetal hemoglobin is distributed among the red blood cells is what's really important. So what we would like to see is something more like this. We would like to see patients where all of their cells have lots of fetal hemoglobin. That's going to be the best case scenario if it's really distributed throughout the red blood cell population, kind of uniformly. What does that mean, right? So what is that going to actually mean in terms of the mechanisms of the disease that we just talked about? What it means is that these cells with more fetal hemoglobin are not going to form the polymer, right? So if we go back to this picture here, if we can get 25% fetal hemoglobin in all of the red blood cells, then that means all of them have an equal probability of forming polymer, which is lower than if they have 100% HbS. And the problem is, if half of your cells have 100% of HbF or 50%, and the other half have 100% HbS, that's a problem, because then a lot of the cells can still very easily form polymer and might cause problems. And so what we really care about at the end of the day is not so much this, but it's really how is the polymer, the HbS polymer, distributed throughout the red blood cell population. And, in some ways, this HbF measurement is a nice surrogate for that, but it's not direct. So it's a step removed from what we really care about, which is the polymer, because that is the problem. And additionally, this measurement doesn't say anything about HbA. So for instance, if you're having gene therapy that's giving you HbA, which is the gene therapy trial that's going on at the NIH, or you're a sickle trait individual who naturally makes HbA in addition to HbS, right? This measurement doesn't tell you anything about the distribution of HbA. And similarly, other therapies that don't rely on HbF, this is not going to be useful either. So again, I just say that what matters is the polymer. That is the problem. That's what we want to figure out. And so actually what my lab did, what we've done in the last year is actually come up with a way to measure the distribution. So much like we're measuring distributions of fetal hemoglobin here, we're going to measure distributions of HbS polymer among red blood cells in a blood sample. And so I don't want to get too much into the weeds here, but the idea behind this measurement is that what we're doing is we're measuring oxygen saturation. So this is the same as if you go to the clinic, maybe Dr. Nelson has done that with some folks and puts a little clip basically on the end of your finger, and that clip tells you what your O2 sat is, what your oxygen saturation of your blood is. And so you could do that for, a whole tissue, and it should be, well above 90%. But we can actually do it on individual red blood cells. And so the reason that that's useful is because of this curve right here. And basically what this is showing you is the oxygen saturation for soluble hemoglobin versus polymerized hemoglobin. And what you can see is they're very, very different. So polymerized hemoglobin does not bind oxygen very well, whereas soluble hemoglobin binds it extremely well. And so if you measure the oxygen saturation and you kind of come down in oxygen and you have sickle hemoglobin, what's going to happen is at some point you're going to be following the soluble curve, and then all of a sudden you're going to start making polymer, and the oxygen saturation is just going to drop way down because you're going to move from this curve over to this curve, okay? And so it's really easy to tell whether there's polymer present by measuring the saturation, oxygen saturation in each individual red blood cell. And so this is a device that we've built, the instrument we built to do it. It's another one of these microfluidic devices with this gas control, like I showed you before. Basically just flow red blood cells through this red part here. You control the oxygen tension. And then here we do like an optical readout where we use 2 different wavelengths or colors of light that allow us to see the ratio of those 2 colors. Basically tells us what the oxygen saturation of the red blood cell is, okay? So without getting into the weeds, I'm just going to show you some data, which I think hopefully will be somewhat clarifying. So at high oxygen, this is what you expect, right? So again, up here at high oxygen, we're on this soluble curve. So all the red blood cells look basically the same, okay? So this is what we would call a monomodal distribution. There's one peak here. All the red blood cells have a fairly narrow range of saturations. And that is correlated with their morphology, so their shape, right? It kind of all looks the same. This is what, in our system, this is what those healthy, flexible red blood cells should look like. So they all have soluble hemoglobin in them, no polymer. But when you lower the oxygen, things change. So now we have this high oxygen peak or high saturation peak here. And now we have another peak down here at low saturation. And again, this is what happens when we make this transition from soluble down to polymer, okay? So these cells in this part of the histogram have only soluble hemoglobin, and then these have a lot of polymer in them. And so they're 2 distinct populations of red blood cells that we see pop up when we make this measurement at low oxygen. And again, that's sort of correlated with the shape of the cells. So again, these are the healthy looking cells. You can see these mostly look like these, as we would expect, but these start looking weird. So here's a sickle cell you can see, and then we've got these that have all these little pointy bits, which are basically the fibers extending out of the cell membrane. So these have polymer in them, right? And so we're able to measure how many polymerized cells are in our red blood cell sample at a specific oxygen tension. So that's what this instrument allows us to do. So again, going back to this idea, instead of measuring the distribution of fetal hemoglobin in the sample, we're measuring the distribution of hemoglobin polymer in the sample. We're able to tell you how many of your cells have polymer at a certain oxygen tension. And that's really important. And I'll just show you an application of that, which is actually, we've been working with a group this is actually from Boston Children's Hospital. So they're running a gene therapy trial right now, and it causes the cells to make fetal hemoglobin, like we discussed. And we've actually been monitoring some of their patients using this technology. And so let me just walk through this quickly with you. So what I'm quantifying here with these blue bars on the right is the fraction of cells that are in this small peak here. So this is what we call the polymerized cells. So what is the fraction of red blood cells that have polymer at low oxygen, right? That, again, I told you that, I think that's what we really care about here. And so these are a bunch of controls that are a mixture of things, but basically just folks who are not treated. And you can see they have a lot of red blood cells that have polymer in them, right? We're pushing 80% here, so very high. Okay, so here's a patient before they were treated with gene therapy. Now they had had some transfusions, so they're not as high as these controls because they've got some normal red blood cells floating around. So they're not as high as these controls, but they're still, you know, we're at like 35, 40% of cells with polymer. And then they got treated with gene therapy. And this is right after gene therapy, maybe a month after. Now they've been exchange transfused. So this is actually mostly not their own cells yet. And what you see here happening is this is their own cells now replacing those transfused cells. And then this is kind of steady state where we're at no more of the transfused cells in all of their cells. So this is now their new polymerized cell fraction after gene therapy. And you can see where this is relative to where they were pre-gene therapy and relative to these controls. And it's way, way lower. And this patient's doing quite well clinically as well. So I think that this measurement is telling us exactly what we want to know, that this patient, that making this measurement is telling us what's going on with this patient, right? Their cells are not making polymer, right, at oxygen concentrations that are in happening in the vasculature, and that means that their cells are able to escape and not cause vaso-occlusions, and so they're no longer having the complications we would expect. So we've made a bunch of these measurements, and this is ongoing, but I think this kind of measurement is going to be very useful for evaluating gene therapy, hydroxyurea, and sort of any therapy that's going to work by inhibiting polymer. This is going to tell us how many of those cells are actually making polymer. So I think this is really cool, and I hope, you know, we're working on trying to get this into so we're doing some clinical trials with it. We're partnering with some clinical trials, but we're also trying to actually get a company going that will actually make an instrument that, you know, could eventually be in a clinical lab. So that's where we're headed with this. Okay, so I'm going to switch gears in the last few minutes I have. Ray, what's my time?
You've got about 2 minutes.
Oh, crap. Okay. All right. Well, I'm sorry. I guess that's not surprising that I ran over. All right. Well, let me speed through this then. What's the take home?
Go ahead
here?
and go.
What's that?
Go right ahead.
Okay. All right. I'm going to do this really quickly. So what I want to talk about now is therapy. So how are therapies usually developed? And the way that drugs, small molecules, drugs are usually developed is this pipeline. And don't worry about all the numbers here. What I want you to know about is you identify a target, you make some sort of high throughput assay to screen for drugs against that target. Then you do lead validation, medicinal chemistry to optimize those compounds for clinical use. And then you take them to clinical trial, and then eventually you get FDA approval. Okay, that's the standard drug development pipeline. So the question is, why do we only have 4 sickle cell therapies approved in like 4 decades? So the obvious answer is systemic institutional racism. I think that's the most obvious answer for this. The reason is a lack of funding and a lack of interest and effort on the part of people who control money, which is mostly white people, to want to fund this disease and fund therapies for this disease. So I want to say that explicitly. But there's another major problem, which is that none of the drugs that have been developed using this process, this is how drug development works. And it's never been done that way for sickle cell. And there's some very fundamental reasons for that I can't get into and don't have time to, but be happy to talk to people about another time. But these are the 4 approved therapies, and just to say none of these were developed using this therapeutic pipeline. In particular, there was not this high throughput screening component, right? They didn't have this huge library of compounds to start from to try to find ones that would actually work for sickle cell patients. And so what we've been doing is actually developing an assay to find drugs using high throughput screening that would inhibit HbS polymerization. And the upshot of all of this is that we have that assay. It works. These are the results of that assay. We've been able to screen over 1,000 compounds already, and I think we're scaling up to do tens of thousands at this point. We've actually started talks with a pharmaceutical company to use this in a very large drug screen. And more than that, we've actually found compounds already. So, right, 4 therapies approved in the last 4 decades, and we've already found, you know, half a dozen new compounds that are capable of inhibiting HbS polymerization using high throughput screening. So we're fixing the pipeline. And then also to say that we've used that same whole blood assay that I talked about, I showed you earlier, to actually validate 3 of these compounds. And we already have 3 compounds that we know are as potent as Oxbryta, which is the new compound from Global Blood Therapeutics. So again, to say that we can find them and we can validate them, so we know that we're finding compounds that are not just pipe dreams, but that also might work. So we're a long ways from having something that will go to the clinic, but I think we have fixed a key piece of this broken pipeline for the development of sickle cell therapies, and I'm very, very optimistic about where we're going to go from here. Okay, so that's a summary. I think I don't need to go through all of that again. Kind of showed you that, and you can read it later. I do want to spend just a couple seconds on this slide, if Ray will allow me, which is like many people who are white and privileged, I've been doing a lot of thinking recently about what my obligation is to communities of color, especially in the face of the institutional racism and injustice that we've seen so much of recently. And really, it's not like it's new, but, you know, thinking about it again in a new way and a new light, maybe. And I think at the very least that I can do is be part of and committed to this community, which I do care so much about. And so I just want to talk a little bit about what those commitments are. So one is to continue to make this disease a focus of my research. I do care a lot about this disease, and I care about the people who have to live with it every day. And I'm going to continue to work towards solutions that actually affect patients. And I think I've shown you 2 examples of that today, hopefully. I'm extremely passionate about this disease, and I want to actually make a difference in the clinical care and not just build widgets and not just publish papers, but actually make a difference. And, you know, part of that is bringing new people into this disease, as I mentioned. And I think that is part of the way that we make progress, is building teams with relevant expertise. And I'm going to continue to raise awareness among the groups that I talk to, faculty, students, other researchers, and try to bring more and more attention to this disease in the academic community. Okay, so that's what I do as an academic. But I also want to say that, you know, I have another role, which is as an educator. And so I will going to continue to make myself available as a resource to this community. You know, if you want educational opportunities like this one, or if there's anything that I can do to talk to people, or you just want to email me directly and have a conversation, I'm happy to do that at any time and talk about what's going on in the field. I hope that people will take advantage of that. I also want to say, as an educator, that I think hopefully I can be a point of contact and a resource for folks in this community who, you know, have kids who are interested in higher education, who are young adults who are interested in higher education. If you think about attending the U or some other university and you just want to talk about higher education, I'm happy to make myself available as a resource to talk about that as a higher education educator. And this is my contact info. You probably won't find me in the office much these days, but I am always available via email, and I'm pretty good at responding. So I just want to say that commitment will continue. It's not enough. These things are not enough, but it's a small thing that I can do, and I hope that it will make an impact. Okay, and then I think that then I'm done. I've got some references here that'll just be online for you guys to look at later. So thanks for your time, and I will stop and turn it over to Steve.
Thanks so much, Dr. Wood. As Steve prepares to take over the controls, I just want to again thank everyone for attending SickleSMARTSummer on this Saturday, June 27th. We have 3 dynamic speakers. Dr. Wood just completed his presentation about really understanding the science of sickle cell disease and the research techniques that he is doing to further the understanding and the discoveries that are being made in research labs. I do want to just simply pause and say thank you, Dr. Wood. I am always impressed with your presentations, and it's so fascinating. But your last slide really almost brought me to tears. So I appreciate you intentionally taking a moment to reiterate your commitment to this community. We need more individuals like yourself who utilize your platform and take your privilege to the next level. And I have no doubt that people will take you up on your offer. And so I'm looking forward to the many new opportunities. Without further ado, let's allow Steve Nelson, Dr. Steve Nelson, and he is going to present on disease-modifying therapies for sickle cell disease 2020 and beyond. Go right ahead, Steve.
Great. Well, thank you, Ray, and especially I need to reiterate what Ray said, Dr. Wood, and I'm glad you went over time. And your presentation actually is a perfect segue into what I'm going to speak about. But before I get into the nitty-gritty of treatments, I personally have been struggling to find some hope since George Floyd was murdered 12 blocks from our hospital. And as a fellow white man, I appreciate you calling out the systems and structures that have been barriers to all Americans of color, but especially our sickle cell community. And I so appreciate your taking charge and your interest in this patient population. And the work that you are doing is so exciting, and it gives me hope for our patients, and having a fellow white man as yourself speaking that truth in a forum like this and elsewhere is really inspiring. So Dr. Wood, thank you so much for that. And for patients and families that may be listening or will be listening, I think we've had maybe 30 or 40 of our patients give samples to Dr. Wood's study. If you're wondering, we talk about this rheology study, and we're going to send blood to this guy at the university. Like, what's that about? This is who it is, and it's really exciting. And again, I wish we could all be together in the same room. That's where connections happen. I think the connections are better, and I think one connection last year, your slide of the list of people working in your lab, Dr. Melissa Azul was a first-year fellow and connected with you at that conference last year, and I'm excited to see young physicians getting excited about sickle cell disease as well. And also to Dr. Wood's point, this talk, had I done this when I was in training 30 years ago, would be really short, because I'd be talking about one medicine. And things are improving, and there's some excitement, and we're going to focus on that. So I'm not going to spend too much time on this, because I think Dr. Wood did a very nice job, and with visuals. But basically, what is sickle cell disease? It's an inherited disorder. For those in the audience who will be watching who aren't sure, it's an abnormal hemoglobin. Hemoglobin is what carries oxygen around to the body. The red blood cells cause obstruction. Dr. Wood showed some beautiful cartoons and videos showing that. And this obstruction leads to tissue and organ damage. Again, you've seen these pictures, normal red cell, one that is sickled. This is what it looks like under the microscope. So there are two, and again, this is rudimentary compared to Dr. Wood's videos, but basically when the oxygen is released from the hemoglobin, this is when the red cell sickle and obstruction occurs. And it's not just obstruction, so vaso-occlusion or obstruction. These red cells don't live as long. It's called hemolysis, so the red cells break down. And those two primary processes lead to all of the myriad complications of sickle cell disease. And there is some overlap, but the occlusion that was so clearly illustrated with Dr. Wood's slides can lead to pain. That's the most common clinical situation, but acute chest syndrome, which is the leading cause of death in sickle cell disease, stroke, which is historically had been our most feared complication, but we have ways of now preventing that. The spleen stops working, so patients are at risk for infection. That's the obstruction part, which also can lead to leg ulcers, damaging the kidneys, damaging the bones, mostly the shoulder and hip joints. But the red cell's not living as long. That's anemia. So chronic anemia, fatigue. The more I get better about truly listening to my patients and families, fatigue, I think, is a profound issue with our patients with sickle cell disease, affecting quality of life, and sometimes we don't focus on that enough. The red cells break down and can lead to our blood vessels not functioning as normally because we don't have enough nitric oxide. That can lead to high blood pressure in the lungs, which is also very serious. So these clinical complications can all be targets for new therapies. And there's a lot of work being done. How can we treat leg ulcers better? What medicines can we use to treat the kidney problems that are associated with sickle cell disease? What medications can we use to address pulmonary hypertension? And that's all very exciting. But those are not addressing the root cause, the upstream issue. So yes, I'm happy that there's work ongoing to help us better manage the downstream complications and issues, and that's fine, but we also need to work upstream. We need to do some things to actually prevent all of these things from happening in the first place. So this is from an article from Jane Little, who used to be at the University of Minnesota. She's now back in my home state of North Carolina. And I noticed on your slide, Dr. Wood, you went undergrad at NC State. I did my fellowship at Duke. Sorry about that. We can fight about that.
Also my home state. So.
Okay, excellent, great. And this is looking at potential targets for new therapies and thinking about them in two separate ways. Like we can look at things, we can address the red cell itself, or we can address things that are extrinsic to the red cell. And one would be DNA, which is sort of tricky on this side because there really is no DNA in the red blood cells because the red blood cells don't have a nucleus, but the red cell precursors do in stem cells. And targets for DNA are going to be gene therapy and stem cell transplant. And I'm not going to focus on those. Dr. Wood did a nice, alluded to gene therapy. But next month's session, Dr. Angie Smith from the University of Minnesota is going to focus on gene therapy and stem cell therapy. So certainly that's the most upstream, right? If we can fix this part, then the rest of it gets better. But within the red cell, there are some targets to hemoglobin. Are there some ways that we can affect the hemoglobin, have the patient make more hemoglobin F? Is there a way we can affect the hemoglobin S, especially in its deoxygenated form? And are there some things that we can do once the red cell has already sickled? Are there things we can do to affect the red cell membrane so that it's not as sticky and occludes the system? So there's some things intrinsic to the red cell we can look at, and there's some targets that are outside of the red cell. So if we don't do anything to the red cell itself, it's going to go through that polymerization and sickling process that Dr. Wood so beautifully showed and described. And once that happens, then the floodgates are open, right? We have these red cells, they break down, they don't live as long, so you're anemic, they release free hemoglobin, which decreases our nitric oxide, which can lead to poor blood vessel regulation, especially in the lungs. These red cells, these membranes, when they get to be this sickled shape, they are much stickier to the blood vessel wall. They also help activate platelets and white blood cells. Those are normal cells in our blood. Platelets help keep us from bruising and bleeding, and white cells are our inflammation, infection fighting, immune cells. Those get activated and they play a part in that occlusion of the blood flow. So these are other targets, right? Can we tamp down the inflammation? Can we turn off the platelets in the white blood cells? Can we, thrombophilia means love of clotting, and we know that patients with sickle cell disease are at increased risk of clotting. Can that be a target for therapies? And these are all good and important, and we're going to talk about some of those, but they don't address really the upstream. If we could stop the sickling in the first place, then the rest of this theoretically would be improved. So as I think about, and this slide has changed, thankfully, and certainly in the 90s that was very limited. But when I think more broadly and talk to families about sickle cell management, like what are we going to do, right? Well, the first thing is nothing, and I say nothing in quotes, meaning you just come to clinic, you take your prophylactic penicillin, you hydrate, you manage pain, you get your immunizations, you get all your screening tests that we do in clinic, but we just deal with complications as they happen, right? Or we can do something proactively to make the sickle cell better and not just react to complications. And this really, for the longest time, especially in pediatrics, is what we did. We did preventative things and we educated families, but we just reacted to problems when they happen. And I will say it is our adult colleagues who really forced us as pediatricians to do a better job. And I vividly remember at a National Sickle Cell Conference, Dr. Cage Johnson, African-American man, adult hematologist at USC, basically yelling at us like, what are you waiting for? And his example was beautiful. He said, okay, you have a 2-year-old who is diagnosed with insulin-dependent diabetes. What are you going to do for that patient? Are you just going to have them not eat candy bars and just deal with their DKA and hospitalizations every time it happens? Or are you going to put them on an insulin pump and tightly manage their blood sugars and prevent not just acute DKA, but prevent retinopathy, nephropathy, blood vessel, leg ulcers, things that happen in sickle cell. So you're going to actively, manage this patient to prevent these things. And it's very similar. I thought, well, of course, why would we not be as aggressive with sickle cell patients, right? And because our adult providers see some of the end organ damage that me as a pediatric provider don't see. But when my colleagues, Dr. Boucher, and Dr. Versilati, Dr. Rausch at Hennepin Healthcare, and others across the country see the 30, 40, and 50-year-olds, I need to do a better job as a pediatrician to prevent these things. So this one really, the nothing is not an option anymore in my mind. Hydroxyurea, early therapy, we're going to talk about that. We can give blood transfusions. I can make a patient's hemoglobin S essentially 0 by giving enough blood transfusions. Dr. Gorlin's going to talk about this when I am done. Yes, we can do that, but there are risks to chronic transfusions. There are certain situations where, yes, we do that. That's our recommendation, but not routinely. I put plus minus Endari because L-glutamine is a FDA-approved drug for sickle cell disease. We could have a whole hour conversation about that. It's not something that we're using a lot. We can speak about that. Or stem cell transplant. Those are your choices, and Dr. Smith is going to talk about that next month. But there are some emerging therapies that I want to focus on. A couple have been mentioned already that we will focus on, and then some future studies that are out there. So hydroxyurea, Dr. Wood did speak about this, and it is an amazing medication. This is just a graphic of developmental hematology. Before we're born, when we're a fetus, we are making alpha chains and gamma chains, and that's hemoglobin F. All of us when we're born, we have 90% or more hemoglobin F. Hemoglobin F is very efficient at binding oxygen. It's great. Hemoglobin F does not sickle. And those on the line or watching on Facebook or later, if you are a patient, if you're a parent, you may remember that when your baby was an infant, they didn't have any problems from sickle cell. Patients on the line, that was your experience too, but you probably don't remember not having any problems in the first few months of life. But all of us are born with hemoglobin F. And then we're born, and then we start making beta chains. And that's fine. And beta chains are what make up hemoglobin A, normal hemoglobin. But if you have the 2 sickle cell traits on your beta globin gene, you're making hemoglobin S. And so what hydroxyurea does is multiple things, and we'll get to that, but it mostly is keeping your hemoglobin F elevated. And this is a nice schematic of what hydroxyurea does. You take your hydroxyurea, it actually has a nitric oxide donor. We talked about nitric oxide is low. Nitric oxide is important in blood vessels dilating, especially in the lungs. So that's a really important phenomenon. It also lowers your platelet production. That's what megakaryocytes are. Myeloid is white blood cells. It decreases your white blood count. Those are very good things in sickle cell, except you don't want them to drop too low, which is why those of you who are on it or your kids on it, we have to come to clinic frequently to get blood work done. But hydroxyurea does all these things. It increases your hemoglobin F. It lowers your reticulocyte count. Red cells live longer. You've got nitric oxide. It's really kind of a great drug. It does all of these things, and it's by mouth. Again, it's just for you to look at that, all the good things that it does. Patients live longer, less pain, less chest crises, less transfusions, and it's by mouth, and it's once a day. And this is our publication from a little over a year ago. We are very aggressive at Children's with starting hydroxyurea. The NIH guidelines that came out in 2014, their new ASH guidelines will be coming out hopefully this year, but there was a lot of discussion about hydroxyurea in infants and a lot of discussion about what should the guidelines say. And there was in 2013 at the Sickle Cell Conference, there was a whole 2-hour session about what word are we going to use to talk about hydroxyurea for infants. And it was defined as 9 months or above, because at that time, the only published data for using hydroxyurea in sickle cell was the Baby Hug study, which looked at hydroxyurea in kids 9 months to 18 months of age. So what the guidelines say, the discussion was, do we Do we, does the word say consider? So to me, consider means I think about hydroxyurea, but I don't say anything to the parents or the family. Or do we offer, which means, yes, I'm going to talk about hydroxyurea to the family and the patient. Do we recommend, which means, yes, I'm going to talk about hydroxyurea to the parents of this infant, and I'm going to say, I think you should do this. Or do we treat, which means we just do it without any shared decision-making or conversation or risk-benefit analysis or discussion. And certainly that's not the way to practice medicine in general. The guidelines say offer, but we are more aggressive. We recommend. And we start hydroxyurea as young as 5 months of age. And this was our, publishing our data. And this is just one slide. And hydroxyurea does a lot of things, but arguably the most important thing it does is increase your hemoglobin F. And you can see what the hemoglobin F levels were much higher if you started hydroxyurea in the first year of life versus between 1 and 2 years of age or greater than 2 years of age. And we'll have some follow-up data on this. And really, the higher the F, the better. There are some barriers to hydroxyurea use. And Dr. Wood mentioned some of them, and also some barriers to why we only have 4 FDA-approved drugs to treat sickle cell disease. There are system issues. There's racism and institutional structural racism and whiteness that affects our decision-making as providers, especially white providers. There's some fear and mistrust of the healthcare system more broadly, although sickle cell disease is a global disorder affecting people of all races. In the United States, virtually all of the patients are Black. And there is a legacy of racism and experimentation on Black Americans that can lead to fear and mistrust of the healthcare system more broadly, but also this particular drug. Because if you go on the Google and type in hydroxyurea, cancer, there's a drug to treat leukemia back in the 60s. So there can be some concern about it. And then community advocacy and public awareness are, as Dr. Wood very astutely described, one of the issues is advocacy and public awareness. HIV was described in 1981, and there are 41 FDA-approved drugs to treat HIV, and that's fantastic. We've known about sickle cell disease since 1910, was the first case report. Been around longer than that, but yet we only have 4 FDA-approved drugs to treat sickle cell disease. So there are many, many barriers to hydroxyurea use. And one of it is, fear on our part, the provider's part. My assumption may be that the family won't do it. They won't come for all the lab work, or I'm scared of using this drug in a young infant, or what dose do we use? So, circling back to the sort of the choices of doing nothing, stem cell transplant, chronic transfusions, or hydroxyurea. This is a table from an article about 4 or 5 years ago from the Belgian group. The Belgians used to get up and yell at us at the meetings too. They were very aggressive with stem cell transplant. If they had an infant, and even up to as young as 2 years of age, if that child had a matched sibling for stem cell transplant them. What are you waiting for? Do a bone marrow transplant before any significant complications happen. That's curative intent. And over time, they've been somewhat changing their tune. In the United States, we tend to be a little less aggressive with stem cell transplant because it's risky. Requires chemotherapy. Dr. Smith's going to talk about it next month. There's, depending upon the age of the patient and the donor and what kind of donor, it's a sibling or not, or someone you're related to or not, mortality can be 3 to 10%, risk of dying from the procedure. And this is a Kaplan-Meier survival plot looking at, over about 15 years. The dark line is stem cell transplant. So for the first few years, it looks great, but then you can see the survival really drops. And the double dotted line is the no treatment, is the like doing nothing, but just, dealing with complications. It's about the same as stem cell transplant over, a decade. And then if you look at chronic transfusions, that's what CT stands for, or hydroxyurea, they're almost the same. And actually better than doing nothing or over time stem cell transplant. And Dr. Gorlin's going to talk about transfusions, but of the 2, monthly transfusions versus hydroxyurea, I would posit that hydroxyurea would be the better choice as far as complications. So how can we optimize our hydroxyurea? I mean, one thing we are doing in our clinic to try to break down one of the barriers is Ray Blaylock. So having Ray on our team, you know, taking, I think when she's in that role, it's both your community hat and your children's hat, really helping break down some of the fear and mistrust of our team, especially, and Ray has been very good about getting me and us to talk about all of these choices with every patient. Talk about stem cell transplant, talk about gene therapy, talk about all these things early on, not just when I think it's appropriate to talk about it or if I think the patient, you know, would do it. And I do have to give kudos to Ray. You know, about 90% of our new babies diagnosed on newborn screening are on hydroxyurea before their first birthday. And I think that is, I'm very proud of that. And I think it's really helping these patients and families. The other piece about hydroxyurea is the dose. The dosing range is so wide. And to Dr. Wood's slide about the different patients who are on hydroxyurea had very different, you know, hematologic and clinical responses. And some of that is, you know, the dosing can be, we typically dose it by weight. It could be anywhere from 15 to 35 milligrams per your body weight. And historically, especially early on in young infants, you know, some centers are very ginger. We start at 5, and then we go up to 10 2 months later. Then we go up to 15 2 months later. And then it's a year and you're still trying to figure out, you know, what is the best dose. And, you know, red cells live 3 months. It can take 3 to 6 months to get the full benefit. And sometimes if it's taking months and years to get the dosing where you want it, that can be frustrating for patients and families. I'm like, this isn't working, and we stop doing it. So we are part of a study called the HOPS trial. HOPS, not to make beer, sadly, but HOPS, hydroxyurea optimization through precision study. We have 2 patients on it so far. I'm hoping we'll get more, but basically it's a way, patient comes in as young as 6 months, you know, could be older, but so far it's been 2 infants, and they get a single dose of hydroxyurea. That's the dose, 20 per kilo was used on the baby hug study. And then they get 3 blood draws, just a tiny little finger poke, and they get 15 minutes, 1 hour, and 3 hours later, we send those samples to Cincinnati Children's. Dr. Patrick McGann is the PI. There's 12 centers, mostly in the Midwest, but also Boston Children's and Atlanta are part of this consortium. And after about 5 days, at Cincinnati, they do a pharmacokinetic testing, and they come to us and tell us this patient's maximally tolerated dose. And it's randomized between the targeted dosing based on this study versus how you would typically manage your patient. But they can precisely come back and say, this patient's dose is 26 milligrams per kilo. This one is 19. This one is 34. And you start them on that dose, and that's their dose. And you can get clinical and hematologic responses much more quickly. So we're very excited about being part of this study. So it's not a new therapy per se, but I think it's a very important study to evaluate how we can better use hydroxyurea in our patients. Gene therapy is certainly an emerging therapy. Dr. Wood touched on it. Dr. Smith's going to talk about it more. There are many open trials. There are many different ways to do gene therapy. There is an open trial at the University of Minnesota. We have hopefully 1 patient enrolling soon. That's the Bluebird Bio trial. I'm sure Dr. Smith will talk about that more. So I'm not going to talk about that as an emerging therapy, but I will have to say this is one of the most exciting potential emerging therapies, as this could be a curative therapy for every patient, because it doesn't require a donor. You're using your own stem cells. So that's very exciting. So I want to talk about the 2 recently approved drugs, and then we'll end with some other potential drugs that are hopefully coming down the pike. But crizanlizumab, which is works extrinsic to the red cell, and it's targeting something called P-selectin, that vessel occlusion that you saw so beautifully in Dr. Wood's talk. You know, white cells are involved in that, platelets are involved with that, and typically it's through this protein called P-selectin that gets these white cells to bind to the lining of the blood vessel wall and leads to occlusion. There have been many agents that have used P-selectin or other selectins as targets for this. Rivapansel studies are ongoing for patients who are inpatient for pain. It's an IV infusion every 12 hours. Tinzaparin is a type of heparin blood thinner. I think all of these are. And then lastly, crizanlizumab, which is Adakveo. Last year's conference, we were talking about this sort of more in an abstract way, but it is now FDA approved. It is a monoclonal antibody against P-selectin. It's IV over 30 minutes. You get a dose, then you get a dose 2 weeks later, and then it's monthly for 1 year. We have used it so far in one patient. Its approval was based on this study, the SUSTAIN study, that had about 65 patients in each arm, placebo, low dose, high dose infusions, as we talked about. And the endpoint was pain crises, sickle cell pain crises. And with the higher dose Adakveo, the rate of pain crises was half that of the placebo arm, which is huge. And I also thought this was interesting, the number of patients who had no pain crises during that year of the study. A third of the patients had no pain crises at all, and only a sixth of the patients on the placebo arm. So it was approved in November. Serious adverse events were reported in all groups. Mostly were joint aches, some GI upset, pruritus, vomiting, and chest pain, mostly during the infusion. But for the most part, it's been very well tolerated. So this is an important disease-modifying therapy. The higher dose is what's being used. And again, we have used it just in one patient so far. I think part of the delay for us was COVID and getting it through our Pharmacy and Therapeutics Committee, but we did get it up and running. This is approved for patients with all kinds of sickle cell disease, SS, SC, STHAL, doesn't matter, 16 years of age and older. So the next one is voxelotor or Oxbryta, which really targets intrinsic, something within the red blood cell. And it really affects oxygen avidity. Again, Dr. Wood, what a beautiful setup for me. Sickle cells don't bind oxygen as efficiently. And because they don't bind oxygen, there's less oxygen, so they sickle more. And if there was a way to increase oxygen affinity, that could be very beneficial. And I love that Dr. Wood has a few molecules in mind just through his work that does this even better than what Oxbryta does. This is very exciting. You know, hemoglobin F has increased oxygen affinity. You know, hydroxyurea, we're using that quite a bit. But can we do better, right? What voxelotor does, Oxbryta, was improved in November. It binds to the alpha globin chain of your hemoglobin. It typically binds about 20 to 30% of the hemoglobin molecules within the red cell. And it shifts the oxygen dissociation curve to the left, meaning it makes the hemoglobin S hold on to oxygen more tightly, so it doesn't get into that deoxygenated state that leads to the polymerization and sickling that you could see with your very eyes so beautifully on Dr. Wood's slides earlier. The approval was based on the HOPE trial, which was randomized placebo, lower dose, higher dose placebo. There were 274 patients initially. These are the numbers that completed the 24-week trial. You can see it is approved for patients 12 and older. I will say that GBT has an ongoing HOPE Kids trial that we at Children's are applying to be a part of that multi-institution study. And it's looking at Oxbryta for kids as young as 4 years of age. And it's a liquid preparation, which is going to be necessary for young kids. So we're very excited about that. So Oxbryta is approved for kids with any kind of sickle cell disease, just like Adakveo, SS, SC, S-Thal, doesn't matter, 12 years of age and older. The primary endpoint for this study was increase in hemoglobin greater than 1 gram by 24 weeks, but even by 12 weeks, more than half of the patients reached a hemoglobin greater than 1 gram. This is a waterfall plot looking at some of the patients. Patients were on hydroxyurea or not. On the HOPE study, 2/3 of patients were on hydroxyurea. I envision using Oxbryta in addition to hydroxyurea, not instead of, although, you know, patients may be more willing, to our talk before, fear and mistrust, and may be more willing to try this by itself. This is interesting, an ongoing study that GBT is doing looking at Oxbryta's effect on TCD velocities. Those parents and patients who are watching this, if you have SS, when you come to clinic once a year, starting at age 2, you get this ultrasound of your head until age 16. It's a way for us to predict stroke. And we know hydroxyurea improves TCD velocities and decreases stroke risk. And although the study's not done yet, it appears that Oxbryta may also be important in decreasing your stroke risk. What's interesting, so the higher doses, what worked better, so 1,500 milligrams once a day, that's what it's approved for patients 12 and older, and with hemoglobin increased by at least 1 gram. Interestingly, 1/4 of the patients on the study, their hemoglobins went up by 2 grams, and which is really very exciting. We are now using it, I think 5 patients are maybe on it. We've got 2 in process of giving the drug. I'm very excited about it, and what I'm excited about is that it really is focusing upstream. You know, Adakveo is great, I'm excited about it, but that's really downstream. The horse has already left the barn. There's already sickling and adhesion. You know, the Adakveo can help clean that up. But this is upstream. This is trying to prevent the polymerization and sickling happening in the first place, so that we don't see those, you know, downstream effects. So just a couple more slides. I want to be sensitive to Dr. Gorlin's time. Just a nice timeline. So 1910, sickle cell disease was described in the Annals of Internal Medicine, the November issue by James Herrick. He described a young man with sickle cell disease from the island of Grenada. He was going to dental school in Chicago at the time. And he had what today we would call acute chest syndrome. And there, in 2010, there was a symposium at the NIH called the Herrick Symposium. It was awesome, it was great, but it should have been called the Walter Clement Noel Symposium, because that was the name of the patient. And just to sort of call out my fish in the water and not seeing things, I've known since my residency about James Herrick and 1910 and James Herrick and Dr. Herrick, and he described the first patient. Well, what was the patient's name? You know, what was his story? Right? Why are we here? You know, we are here to help the Walter Clement Noels of the world. So 1910, we've known about this. This is the first molecular disease. 1949, we understood the molecular basis of sickle cell disease. Well, here we are 71 years later. Why is there no cure? Right? There are many reasons for this, some of which is the legacy of structural racism and funding disparities, and just how we talk about sickle cell disease. And I fall into it sometimes, 1 in 365 African Americans, as opposed to saying 1 in 2,500 Americans, right? And I think if we continue to think about this as a Black person's disease, those in power who make decisions about policies and certainly funding, if that's how we're thinking about this, then subconsciously it affects our decision making. So we've known about this for a long time, and we have a long way to go. Prophylactic penicillin study, 1986. The STOP study was when we discovered that we can help predict stroke by doing these ultrasounds every year. Hydroxyurea was FDA approved in 1998. It wasn't approved in children down to age 2 until 2 years ago. The baby hug study, the Hug Kids trial, that's for kids down to toddler age for hydroxyurea. 2006, World Health Organization recognizes sickle cell as a global health crisis. Well, it's been a global health crisis for hundreds of years. Stem cell transplants really started to take off. You know, the first one was done long before this, but trials really showing its benefit. The baby hug study, 2012, that's using hydroxyurea in kids as young as 9 months of age, and now we're really pushing that envelope even younger. Gene therapy, 2017, and now there's many ongoing trials. Adakveo, also L-glutamine was approved in 2017. Adakveo studies came out, and then November, just this past November, FDA approval for Oxbryta and for Adakveo. I'm very excited about. And with all of this, there's still only 4 drugs for us to choose from. And we have a lot more work to do. And it is exciting. I'm very excited for many reasons about Dr. Wood's work. But if you go on clinicaltrials.gov right now, there are 118 actively recruiting clinical trials for sickle cell disease in the United States, which is really exciting. And I just wanted to call out a few of them, a few medications. There are 2 drugs, before they're approved, there are a bunch of letters and numbers. There are 2 medicines that are activating something called pyruvate kinase, so AG334, FT4202. Pyruvate kinase is an enzyme that's in our red blood cells that we all have. It helps our red blood cells live. Because our red blood cells don't have a nucleus, our red blood cells have to rely upon glycolysis, and there's a whole bunch of enzymes that you memorized in your medical school biochemistry, and we can be deficient in any number of those, and that can lead to red cell breakdown. But these are both very exciting drugs. There's a drug called, it's SCD-101 is what it's called. It's an oral anti-sickling agent. Because it's investigational, it's very I'm not really quite sure what the mechanism of action is here, but there's some ongoing trials of this oral agent. And then this IMR-687 is an oral PDE9 inhibitor, which is important in nitric oxide metabolism and vasomotor activity and vasodilation, which would be very exciting for things like pulmonary hypertension and potentially priapism. Again, this one would be more of a downstream intervention, not upstream. And this last slide, I think it's my last one, just looking at new agents, sort of how to think about them, risk tolerance and potential for improvement, right? If you're way upstream and an intervention that can cure you, right, or prevent sickling. So if you can go upstream, these downstream things are going to go away, right? All the pain, end organ damage. If you can intervene up here and fix all of it, if you will, then you might be more willing to accept some risk. Right? For gene therapy, it's not without risks. There is, for all the trials that I know about, you do get a single dose of IV busulfan. It's a chemotherapy drug. Dr. Smith will talk about that. Certainly stem cell transplant is even riskier. But the hope is that you're cured, right? So it's all about risk benefits. I think in every family has, in every case, it is different. But the further you get down to, okay, I'm going to take a new drug that only helps, my kidneys, but doesn't help anything else, am I willing to take a lot more side effects? So this is just a way, the way that I like to think about new things that are coming down the pike as I talk with patients and families about the risk benefit, right? What's the payoff, right? My investment, what's my return on investment? How risky is this? And how much improvement am I going to be able to see? So I do like this. And this is really a great article, actually, by Jane Little. And I can get this to you, Ray, and to distribute to people, the whole article. It had a lot more in it than just what we talked about, which is very exciting. So I'm going to end there as it's 11:25, so that Dr. Gorlin has time for his talk. Thank you.
Thank you, Dr. Nelson. That was incredible. There's so much to be looking forward to on the horizon. Just the fact that we have 3 new disease-modifying therapies in just the last 2.5 years is absolutely amazing. And even when my son was born, as much as I prayed about this day, it was really hard to see that light. And the light is there, and it's exciting. And so I do know that we are a little bit off time. I want to make sure that that Jed knows that you can go as long as you need to. I invite everyone to stay for however many minutes that we go over. I am actually very thrilled to have Dr. Gorlin with us. Dr. Gorlin, I have given you co-host, so I'm going to let you go ahead and take control of the screen so you can get your slides up and going while I'm talking. I want to remind everyone that this is the June session of SickleSMARTSummer, and we are very excited to be offering this to the broader sickle cell community, both locally and nationally, as well as globally. We are not only is this a Zoom meeting, but we are also showing this in Facebook Live through our Facebook site, and so it is accessible by people all over the world, and we're really excited that we're able to do that. I spoke a little bit earlier about Dr. Nelson, and that he is near and dear to my heart as my son's, when my son was in pediatric care, he was my son's hematologist, and I continue to work side by side with him at Children's Minnesota, and I would not have the role that I have as a sickle cell health advocate and care coordinator at Children's if it wasn't for Dr. Nelson. But Dr. Gorlin, I have to say, holds an equal space in my heart. And true story here, I like to say he found me on the streets of North Minneapolis. My son was very small. I think he was maybe 6 years old at the time. He's 24 now. So I've known Dr. Gorlin for a very long time. He's been committed to this cause. He brought the sickle cell program to Memorial Blood Centers. He'll talk, I'm sure, a little bit about that. But without further ado, please welcome Dr. Jed Gorlin, who will talk about transfusion and sickle cell disease. Dr. Gorlin, take it away.
Thank you. I think I'm unmuted. Can you hear me? Good.
Yes, we hear you.
So I will zoom through a lot of these slides since Dr. Wood and Steve Nelson did such a fantastic job creating the foundation for it. I will remind you that September is Sickle Cell Anemia Awareness Month. There are some wonderful stories that have been collected by the Minnesota State Department of Health. And just a brief digression, there was some effort by some rather unfortunate people to really hamper newborn screening and try to make it an opt-in, which would be really not in the benefit of pediatric patients born with various genetic illnesses. And I suggested that they talk to my spouse, who was at that point collecting stories via the StoryCorps legacy. And so we met with the Minnesota State Department of Health, and they've since put these stories on. But the StoryCorps legacy program, including collecting stories of patients and families with hemophilia, also collected those stories from the families themselves, and they are available at the Smithsonian African American Museum. So a shout out to the families that shared their stories. So you've already heard all about this background and are well familiar with it, so we'll copy that. And you know about the genetics. There are various modifications depending upon the exact genetic basis, and between Steve and Dave, they've reviewed those. The reason it is most commonly found in the Black population in the United States is a single gene carrying the sickle cell trait is significantly protective against one of the more severe forms of malaria. And that's because the red cells don't live as long, and then the malarial parasite can't grow as much. The significance of which I'd just like to point out is that much of the recent immigration to the Minneapolis area from the Somali and Ethiopia and Sudan community was not the hotbed of malaria. And so it actually hasn't increased the number of sickle cell patients that much. Certainly there are some, but it is much less frequent in East African, people of East African origin than West African. This is a slide from Steve Nelson, who will probably recognize it. So long before white doctors in Chicago and Detroit learned about sickle cell, there were names for it in Africa, and they typically related to how painful the painful crises were. And you've heard about the pathophysiology, but I do like this slide showing that you can actually see in electron micrographs these polymerized rods are really hemoglobin molecules all lined up in a way that makes them stick together and not come apart, not go back into solution very well. Resulting in the sickling that Dr. Woods showed you actually videos of, which leads to both, as Steve mentioned, the hemolysis and the vessel occlusion and all the consequent complications thereof. So transfusion, which patients, as Steve said, I mean, part of what Dr. Woods is studying is how can you have the same genetic change in people with, standard hemoglobin S and have such varied outcomes. And one of the things that Steve mentioned was those serial ultrasounds, because stroke is such a feared complication. If you can prevent the development of that, then that's a good thing. And so those people who are showing rates of carotid artery narrowing by higher flow on the carotid ultrasounds are the best candidates for chronic transfusion, because you can largely arrest the increased rate of stroke in those patients by transfusion. As Steve mentioned, however, transfusion is not without its own consequences. With each dose of red cells, you get a dose of iron, and that can lead to iron toxicity, or at least the requirement to be removing chelating iron. And you can make antibodies over time, which will be the subject of much of the rest of the talk. As Dr. Woods pointed out, the genetic basis may be simple, but all of the mayhem that follows is really complex and the subject of his lab, so I won't further deliberate on that. I do want to draw a little bit of attention to the hydroxyurea history. This slide is a little bit out of order. So actually maybe I will go ahead. Well, yeah, I'll deal with it now, just for time's sake. I have a slide going ahead. There was a wonderful study of efficacy of hydroxyurea in I believe a Nigerian population, but the comment of the study, and this was presented at the American Society of Hematology in like 2001, was that virtually nobody in the community had access to hydroxyurea. And there's an article in this month's New England Journal of Medicine looking at a fixed dose versus variable dose hydroxyurea in patients in Uganda. And one of my Canadian colleagues, Dr. Heather Hume, was part of this, as well as Dr. Shandi John, who was at the University of Minnesota, now at Indiana, participated. And it showed that the dose escalation groups, i.e. optimizing hydroxyurea, helped, although they still note that many patients still have no access to hydroxyurea. So new developments, newborn screening. I am sad to say that I'm of an age that when I came to the blood center here, I'm not sure people realize what an amazing State Department of Health we have, and what an amazing newborn screening program. Minnesota was one of the first to be screening for, not the first, but one of the first to be screening for sickle cell as part of the newborn screen. The Dakotas were not doing it as of 1997 when I came. And I actually had a discussion with their State Department of Health about that very subject. And I'm proud to say they're doing it. I suspect it had nothing to do with me and a lot to do with just catching up with the times. And I think Steve has really nicely addressed most of the rest of these, so I won't do that. Ray and I had the honor of being at the post office opening of when this stamp came out in 2004. You know, it was celebrating the fact that by 2004, in fact, all 50 states were had finally gotten around to screening. And it's vital to have that early diagnosis. Unfortunately, there were kids that were being diagnosed with sickle cell at autopsy because they got overwhelming pneumococcal sepsis because nobody knew they had sickle cell. And you can completely prevent that by just taking the penicillin prophylaxis, as well as being alert for splenic sequestration, which can be a rapidly fatal complication if you're not aware of it. So many more. The STOP trial was based off the transcranial Doppler erythrocytophoresis as a way of decreasing the iron overload. There are children's hospitals that take out the red cells with a machine called erythrocytophoresis. Whoops. And then the good part about that is you reduce the amount of iron transfused with each transfusion. The bad part is it takes double the number of red cells. So you're sort of exchanging that for a higher risk of making antibodies against red cells called alloimmunization. And I think Steve and Dr. Woods addressed many of these other new developments. This is the reference I was talking to, a 2007 study where literally in 1,000 sickle cell patients in Nigeria, 0 were on hydroxyurea and only 5% were aware. So that's what what a progress a decade makes. That it's now, in urban areas in sub-Saharan Africa much more available. So transfusion, why would you transfuse? It's typically one of 2 reasons. There's the chronic transfusion or acute transfusion. In acute transfusion, you're doing it either to increase oxygen carrying capacity. For example, if there's a kind of crisis where you're not making enough red cells, and if your red cells last 120 days and you get parvovirus infection that turns off your blood factory for 3 weeks, it doesn't really matter much because your red cells last 3 months, which is a lot longer than 3 weeks. If your red cells only last 3 weeks and your blood factory turns off for 3 weeks, you're in trouble. And so that's why these aplastic crises are such a big deal in sickle cell. And so transfusion is needed for that. Once you make antibodies against parvovirus, you generally don't get it again. So it's not a recurrent problem. And then alternatively is to replace abnormal cells. So for example, in chronic transfusion, we're trying to get the sickle hemoglobin level below 30% up front, but below 50% on a chronic basis. And that will dramatically decrease, not eliminate, but decrease the likelihood of the sickle cell complications. So simple transfusion versus exchange. A simple transfusion can, if done repetitively, decrease the hemoglobin S below certain levels. But because you're increasing the hemoglobin and the blood gets more thick, more viscous at higher levels, you can actually precipitate sickle cell crises by getting the hemoglobin level too high. So generally, we only do simple transfusions when the starting hemoglobin is a relatively low value, say below 5 or 5.5. Exchange transfusion, where we're taking out the sickle cell, we generally reserve for more severe complications, acute chest, splenic sequestration, some of these really life-threatening indications, or signs that there's a stroke about to happen. Okay. So less proven reasons to transfuse. Perioperatively, there are clearly operations that are going to compromise the patient's ability to breathe well and hence maintain good oxygenation. And so it has generally been thought it was a good idea to do transfuse prior to those operations that would put patients at risk. The downside is the risk of forming antibodies. And so we do that only with some reluctance. And as surgical techniques have improved and perioperative care has improved, that's actually less commonly done. Pregnant patients with sickle cell disease, there was a study out of Jamaica which did this. And the good part is it decreased some complications. The bad part is it dramatically increased alloimmunization. Now that was done 30 years ago before we had as fine matching as we do. Leg ulcers, priapism, and acute painful episodes, generally we discourage because it's not clear how effective it is and certainly has its complications. So what are the complications of red cell transfusion? Well, volume overload. One of the ways you compensate for anemia is to increase your blood volume. So many patients with sickle cell in their baseline state actually have an already generous blood volume, and there's only so much volume you can give, and you can actually sort of back the heart up. You can fluid overload the cardiovascular system with blood given too fast. Hyperviscosity, as I mentioned, even at a hemoglobin of 7 or 8, the blood, if all the red cells have hemoglobin S, is almost as viscous as a hemoglobin of 14 or 15. So you can actually make the blood thicker and more at risk for stroke and other complications by getting too high a hemoglobin. Making the antibodies, alloimmunization, which we'll discuss more. Hyperhemolytic, if you make antibodies, and you may not only break down the transfused cells, you may break down your own cells. That's called hyperhemolytic syndrome. And then, as I mentioned, iron overload. Each bag of blood has about 200 mils of iron, which has each mil of red cells has 1 milligram of iron. So one bag of red cells has 200 to 250 milligrams of iron, and your body has ways of managing iron absorption. It doesn't actually have ways of getting rid of iron because that was, from an evolutionary standpoint, just didn't happen too much. People weren't good enough hunters to be eating meat all the time. So volume overload. Generally, one of the reasons why it takes a long time in clinic when you're getting transfused is we suggest maximum rates, which transmit are things like 1 to 2 mils per kilogram per hour. But functionally, what that means is that bag of blood is going to take 2, 3, maybe even 4 hours to go in, depending upon how fast you can tolerate that transfusion. And sometimes they give it with things that help you eliminate water, called diuretics. But this is people that don't tolerate the volume shift well, maybe those that benefit from exchange as opposed to simple transfusion. So viscosity. Viscosity is resistance to flow, and it is not linear to the hemoglobin. So it's not like if you double the hemoglobin, you double the viscosity. It's more like you double the hemoglobin, you increase the viscosity 4-fold. So it really goes up as you get to higher hemoglobins. And sadly, the Belgian national bike racing team, since I see Larry Silber there, actually lost several members when they were taking erythropoietin, got their hemoglobin levels up very high, and then went out biking on a hot day, which hemo concentrates you. As you lose fluid, the hemoglobin concentration goes up, and they got strokes, and several of them died. So more blood is not necessarily better for you, and it's certainly always bad to cheat in biking sports. So how do we prevent hyperviscosity reactions? We avoid over rapid transfusions and avoid transfusing the hemoglobin levels higher than 10. So 10 would be considered anemia for most folks, but 10 is plenty high for patients with sickle cell. When you have 20, 30, 40% hemoglobin S, you don't want to go higher than that. So the immunologic can be forming antibodies against things on red cells, antigens on red cells that are different than your own. And when we're transfusing patients with sickle cell, A positive or B negative isn't a good enough match. We're matching for C's and E's and Kel's and a whole bunch of other thingy-dingies that are now on red cells. As I mentioned, with hyperhemolysis, when you make those allo antibodies, you can also make antibodies against your own, or at least cause the breakdown of your own red cells, and that's called hyperhemolytic syndrome. There are the non-immunologic complications that I've mentioned, hyperviscosity, iron overload, and transmission of infectious disease. Now, as a medical director of Memorial Blood Center, I can say in the 23 years that I have been at the Blood Center, I am actually unaware of any transmissions of disease in the last decade. And some of the ones that I'm aware of from before that were actually malaria, not the things that we can screen for, like hepatitis B, C, or HIV. So we are really good at screening for the things that we can screen for. And we now even screen for things like Babesia and Zika. It's the things that we can't screen for that are more worrisome, and I'll talk about that in a bit. So alloimmunization is a particular problem. In addition to matching for the ABO blood group and the D, we match for the RH subtypes, big C, big E, and Kel. And depending upon if somebody's already started forming antibodies, we may be matching for things in the KID series, JK, A, and B, the Duffy series, A and B, and maybe MNS as well, typically big S. So alloimmunization is a big problem. Typically, a quarter to a half of chronically transfused patients have red cell antibodies, and that can make it very difficult to find well-matched blood. Part of that is for the fact that many of our donors are of Caucasian background, and most patients with sickle cell are not. And so with different ethnicities, you're going to have different characteristics on the red cells. So there is no such thing as white blood or black blood. It's just that folks who came originally from sub-Saharan Africa are far less likely to have big C or big E or some of the other antigens that are more common in the typical US donor population. So we actually recently had a patient who required an exchange where only 1 out of 20 to 40,000 donors had a blood that would be compatible. And so that's the thing you want to avoid, is getting into the situation where you have made antibodies. So any antibodies that we can prevent forming make it that much easier to transfuse somebody when they do need to be transfused. So problems arising, it can be very difficult to find the compatible units. You don't want to have people make antibodies that could potentially cross the placenta and cause problems when they are pregnant, so hemolytic disease of the newborn. And it can cause delayed hemolytic transfusion reactions. Sometimes these antibodies disappear and we can't see them, but you transfuse somebody, and then 2-3 weeks later, that transfusion is already gone. And when it's particularly vigorous, when the antibody returns, that's the hyperhemolytic syndrome. So what are the antibodies that people most commonly make? Well, they most commonly make antibodies in the RH series, the big C, the big E, the JK, the KID series, the Duffy, more typically against Duffy A, big S, and Kel. Kel is easy because most donors don't have it, so that's an easy one to get around. But when you start having combinations of these, less and less donors actually match. So how can we prevent the red cell immunization? Don't transfuse if you don't need it. And so one of my jobs at Boston Children's Hospital was to go around and try to dissuade over-enthusiastic physicians from transfusing patients just because they happen to have a hemoglobin of 7. Many patients with sickle cell anemia walk around with hemoglobin of 7 and tolerate it just fine. So to have a lower transfusion trigger in this patient population than they might in other populations. Phenotyping or genotyping the sickle cell patients, and I'll talk more about that in a second. Trying to match as well as possible, and it's now pretty much the standard of practice for sickle cell centers to be matching for all of these. But if you get a transfusion in a rural area, they may not know about this, and that's why we provide the transfusion cards that I'll talk about in just a second to help those less informed about the importance of the more extended matching. So what is genotyping? Genotyping is looking at the DNA to find out what are all those thingy-dingies on the red cells. What are the antigens, not just the ABO, but all of these other ones that I was talking about, the RH, the Duffys, the KIDs, et cetera. So my colleague, Dr. Van Buren, recently wrote a lovely article for our transfusion journal on how do I incorporate red cell genotyping to improve chronic transfusion therapy, and described a program that we have in collaboration with Children's Hospital, where basically all of the thalassemia patients and all of the sickle cell patients, even before they need to be transfused, we ask for a genotype to be sent, and that goes to the reference lab. And if there are variant or weak or discordant antigens, we might need to do some additional testing. And one of the challenges in the sickle cell population is these what's called variant antigens, and I'll talk more about that. If the antibody screen is positive, then we identify those antibodies and make sure we're know about them in advance. So this is an example of all the different things. There are Diegos and Dombrocks and Colton, so there's an entire alphabet soup of antigens that are typically not on the top of mind. It is not possible to match for every single one of these, but knowing this, and we do the genotyping on donors as well as patients, then we can help find the best match for those patients that do have antibodies. Of note, we did detect antibodies in at least some of the patients. So at enrollment, about 30% of the patients with sickle cell already had an antibody, and 2 developed them during the course, even though we were providing the super special matched. And part of it was one of the patients turned out that they tested as RH positive or D positive, but they had a variant D. So even though we were giving them blood that was seemingly compatible, because they had this variant, they could make antibodies against something that was different in a different portion of the molecule. And making auto antibodies is not a rare event when people get chronic transfusions, and that was the other antibody. There was also a fair number of variant RH alleles, and this is a challenge because even when you know it, there's not a whole lot of other donors that have those exact same variants. So this is mostly useful when people are getting in trouble making antibodies, and then we can see if we can find cells that are either completely lack those antigens or at least have similar enough variants. But some of the variants are why just because you're matching for things doesn't mean that you can 100% of the time prevent antibody formation. So one of the things we're really proud of is this card that Children's Hospital now sends to all the families of the patients that describes, the patient's name, what the antibody is if they have one, what the specific recommendations are that they should receive blood negative for the following set of antigens, and then their specific genotype. And this is a handy card that actually fits in your wallet or purse, and we would encourage families to share this if they're going into a healthcare setting that is outside of their usual healthcare setting, so that the patients can, and it gives the phone number of Children's Transfusion Service, so that if there are questions, there's a 24/7 person there to answer any of those questions. So delayed hemolytic transfusion reaction happens when you make antibodies against something you've seen before. So instead of the blood being broken down right away, it's typically a week or two later. Typically, it's not high enough that it's going to cause kidney failure, but it can certainly drop the hemoglobin level to where it was before, or even lower, because you've now suppressed the patient's own red cell formation. So here's an example where somebody had a hemoglobin of 7, gets 3 units, gets them up to almost 10, but go down to a hemoglobin of 3 as they start destroying the transfused red cells. And something that we do is a medicine called methylprednisolone, which is a steroid, plus gamma globulin, helps clog up the body's ability to chew things up in the immune system. And so it allows the patient to recover, but this is something we'd like to prevent. And so one way to do this is to avoid unnecessary transfusions. I have no idea why the patient was being transfused 3 units when their hemoglobin is already 7. A good question. So if possible, avoid transfusions if you're having hyperhemolytic. If transfusion is necessary, we try to provide the red cells with the best match, and then steroids and IVIG seem to help. So red cell product choices, you can get more volume of red cells per volume transfusion by giving red cell components as opposed to whole blood. In sub-Saharan Africa, whole blood is often the only thing they have available. We try to leukoreduce all the units. That prevents a lot of complications, including febrile transfusion reactions, which is fevers. But you can't leukoreduce a unit from somebody with sickle trait because the cells are stickier and they literally stick to the fibers that are used to take out the white cells. And if all the fibers are covered with red cells, then they won't be taking out the white cells. So about half the units we try to leukoreduce will clog, but the other half that make it through are often not actually leukoreduced because of this phenomenon. Judicious use of transfusion is wise. The hydroxyurea has already been nicely discussed. And you can go to a pretty incredibly low hemoglobin and tolerate it. So at Hennepin County, where I'm also transfusion service director, we're the hospital of choice for the Jehovah's Witness community. And essentially virtually nobody dies with a hemoglobin of 5 or above from anemia. It's not 0, but it's certainly close to that. Once you get to 3, it's about 50% mortality. But below 2, it's 100%. So there are levels below which even young healthy people can't tolerate. So clinical considerations, if you have multiple antibodies, it's very difficult to find compatible units. And we generally will avoid transfusion if you can tolerate a hemoglobin down to 4 or 5. But obviously the risk of mortality goes up dramatically with the hemoglobin below 4. If you've had hyperhemolytic, we would probably pre-treat you with those medicines. Bone marrow transplantation, it sounds like it's going to be a subject of next time's presentation. And gene therapy, you've already heard about. I'm proud to say that Boston Children's had pioneered one of the first ones where under Dr. David Williams, I believe that's the Bluebird therapy, and you'll hear more about that. Well, here's the that clinical trial, which Dr. Williams shared with us last year at the blood banking meeting, and that's been successful to date. And I read on an NPR report that a similar study using CRISPR to actually change the patient's own cells, that patient's now a year out and doing quite well. So it's some really exciting stuff in the future, but in the meantime, transfusion has an important role. So transfusions are, if they're, I can leave you with a few messages. Transfusions today are safer than they ever were before, but there are still some chances of adverse consequences. As for all treatments, all physicians, when we prescribe a treatment, are weighing the benefits and the risks and should be, evaluating alternatives, and we should be discussing those with you. And in many situations, the benefits are substantial. Transfusion can clearly be life-saving in an acute situation, as well as for patients requiring chronic transfusion. The way we have the specially matched blood is to get donors from the same ethnic community, from the African American community. So I'd strongly encourage you to contact Memorial Blood Center at www.mbc.org and set up a blood drive at your church. We're able to do blood drives again, I'm excited to say. It's social distancing, 6 feet apart, which means that you can only have a very limited number of people on the bus at the same time. So we will work with you to be able to draw blood in a safe fashion. But the need for those special match transfusions hasn't gone away just because of COVID. So we are very excited to be able to provide the specially matched blood, but to do that, we need donors like you to come in. So I will end it there and turn it back over to Ray and thank her profusely for the opportunity to share.
Thank you so much, Jed. This was excellent information. I think that we are all learning so much. We're wrapping up today's Sickle Smart Summer. Jed, will you unshare your screen, or I might just have to figure out how to take, there we go. I want to make sure that everyone knows about next month's session for Sickle Smart Summer. And forgive me, I'm multitasking as I'm trying to get the graphic up. But next month, as it's been alluded to several times, we will have 3 more speakers who will speak. We have 2 speakers from St. Jude, but what we'll be talking about is clinical trials. We'll be talking about complications of sickle cell disease, as well as we will also spend some time talking about gene therapy and some of the other curative therapies that are on the horizon. So we are very excited about that, and I can't seem to get the graphic up, but you can find out more information at our website at www.SickleCellMN.org. Again, that's www.SickleCellMN.org. There were a couple of questions that came through. The first question being for Dr. Wood. Were the graphics and the visuals that you shown, were those of actual blood smears of people, or was it a recreated graphic?
Those were real blood samples. Yeah. So everything I showed you was, experiments on, so in the first, when I showed you the hemoglobin polymerization, that was reconstituted sickle hemoglobin, so purified from red blood cells, and then, put into on a microscope slide. But then the things I showed you with the blood and the cells, those were from whole blood samples from patients.
Awesome. That's pretty cool. And it just to be able to see what you see under a microscope, blow it up however many hundreds of times to make it something that we can really wrap our heads around and see what's going on inside our bodies is absolutely amazing. And then I had a question for Dr. Nelson, and that question is, if my doctor has not talked to me about these other options, how do I best get access to them?
That's an excellent question. And maybe that question should be to you, Ray. I mean, it feels like some of it is, how do I advocate for myself, right? And I, the way I think about it as a practitioner, it is my duty to talk with every family about every available option that is there for them. That doesn't mean that I'm going to recommend all of them. Maybe certain ones are not appropriate for certain patients, but I truly believe that it's my responsibility to have those conversations with patients and families. Now, it's not your job necessarily to know all these things, right? A lot of things are happening in the medical community and with sickle cell, which is very exciting. And you can come armed with, this happens all the time. I've been on the internet. I heard an NPR story about gene therapy and this, woman in Nashville or whatever it is. And that's easy for me to say because of the power differential, right? I mean, there's a lot of power in healthcare, physician, patient. But you hopefully can feel empowered to advocate for yourself or your child, because it's your care. And if you're not getting the answers or support that you feel you need, then that's a problem. And perhaps we in the Sickle Cell Foundation can help you maneuver that. Feel free to weigh in, Ray.
No, I absolutely agree. I think that one of the things that we really work on from a community perspective is empowering people. And that is, depending on where you're located, depending on who your primary hematologist is, they may or may have their own opinions and perspectives on some of the new drug therapies. However, I am an advocate as a caregiver myself, as watching a young adult who is really coming into his own as an empowered individual living with sickle cell disease. It's about making informed decisions. Whatever the decision is that you make, it should be one that's informed not just by the internet and social media, not just by what you read, but also what you are able to sit down with a medical expert and talk about, to ask questions. Sometimes I can remember in the early years, I didn't know what I didn't know until I probably already should have known it. Sometimes you just don't know what to ask. Sometimes just simply asking questions in a broad sense. Hey, I think I heard something about some new therapies and new treatments. Can you talk to me, Mr. or Miss Doctor, about all of these new treatments that I'm hearing? Can you tell me both the good and the bad? What do I need to know to make a decision for myself or my child? We may not have the specifics of what to ask, but we can ask very broadly. And to your point, there is a shared responsibility that does live with that provider as well, to stay up to date, to remain knowledgeable, to be able to have sometimes difficult conversations around treatment options and what is best for you, what they feel from a medical perspective may not be best, but also to listen. That's a huge piece of medicine that I think that we as a country can do so much better on. And that is listening to our patients, listening to the families, listening to those who live in the bodies of those who are experiencing sickle cell disease, and allowing their personal expertise to be part of the decision-making process. And so there's many opportunities throughout our day and throughout each and every visit in the medical community to do that. I think that we will continue to do that. And as we, as patients and families have more knowledge, this is one of the reasons why we feel very strongly about this education conference. Some of these things are very high level discussions, and some of these things, I'll be honest with you, Ray Blalard, the founder and executive director of Sickle Cell Foundation of Minnesota, there are things that go over my head. There are times that I have to just smile and nod because I am like, what? I don't understand, but I'm going to absorb it because there may come a time that I get more information down the road, and what I heard a year ago, what I heard 6 months ago starts to make sense, and I feel better equipped to ask the questions and respond accordingly. So I think that all of these presentations have been wonderful. I don't want to miss out on asking Dr. Gorlin a couple of questions. First, there was a comment about the blood transfusion cards and how amazing that would be for every individual living with sickle cell disease once they've had their first transfusion or whenever most appropriate, to be able to have something like that in their possession, particularly when traveling and they may have to see go to a facility, a medical facility they've never had to before. But then the other piece is, I just wanted to call out and clarify, Dr. Gorlin, during COVID, we know that there was a blood supply shortage across the country, but particularly for sickle cell disease, this mattered because there was also an effort to decrease the decision, to look at the decision-making process around when to transfuse. Can you speak a little bit more about what it means to be judicious and inequalities that can happen in the process of trying to find what is judicious and what is just inequitable?
Ooh, so that opens up a bit of a hornet's nest. Just as far as general transfusion, come mid-March, we had to cancel all of our blood drives. 50% of the blood we collect was collected on blood drives, including all those high schools that actually represented some of our better sources of ethnic diversity. So Minnesota donors are amazing, and so they, came in. So we actually had no shortage of blood in the latter part of March and April. The problem is all those donors came in the latter part of March and April. And so now that it's well into June, and more importantly, they're restarting all of those elective surgeries. The amount of blood being used is going, back up to normal, but we're still not back up to normal on blood drives. So yes, there is a relatively low inventory. I wouldn't say shortage, but we have less on our shelves than we'd like. I did, however, participate literally in a national conference yesterday, and there was discussion. There were parts of the country where people on chronic transfusion with sickle cell weren't getting transfused by the exchange system because that uses many more units, and unfortunately those antigen matched units were the ones that were particularly short because that requires donors of African American ancestry to come in, and they're just simply nationwide weren't enough. So I can say, we were in a better position as far as being able to provide those antigen matched units, among other things, because we're now connected with 5 other blood centers. But that was not true nationwide. So at least patients here were relatively fortunate. And to be honest, there's just a lower number of patients here than there are in Atlanta, Georgia, just, to be fair. So it is vitally important that we continue to have good minority donor recruitment so we can meet the need for those special antigen matched units. We're asking that all blood donations be by appointment so we can preserve that safety with donation. And have the 6 foot distance. We can't actually draw blood while 6 feet away. That's beyond possibility. But we certainly are asking all of our donors to be wearing masks, and certainly all the staff are. So we're making do, but but we could do even better with more donations.
Thank you for bringing that out, because it really is, sometimes the match is hard because we really need more donors of color, right? Particularly in places like Minnesota, where it is not a popular thing to do. We really need to do some extra work normalizing blood donations to communities that may not be on their radar, that they may not understand the importance or the significance of what they bring that's so unique and such a lifesaver and such a renewable resource, right? And so that is one of I had the opportunity for many years to work under you, Dr. Gorlin, and I learned so much about blood transfusions. And even for my own son, who received blood transfusions fairly regularly, it was very enlightening for me to understand about the delicate balance of just because his hemoglobin appeared lower than what we'd like it to be doesn't mean that transfusion was the best answer in that moment. And so better understanding that really has helped us to be better patients, and better warriors living with sickle cell disease and partners in our care. So thank you. I don't want to pass up the opportunity to say, hello, Jocelyn, I see you back there.
You look so beautiful, and you're bringing tears to my eyes because I'm so proud of all the great work that you've done.
Thank you, thank you.
You are just inspired, you are divinely inspired, and I just really appreciate all your work.
Thank you. I so appreciate the support of the Gorlins. I appreciate the support of the Dr. Nelson, Dr. Wood, all of our speakers. I appreciate the fact that in Minnesota, it took, one little caregiver like me, right? 24 years ago, I won't even say 24 years ago, because it took me a while to figure this all out and to figure out what my new normal was as a mother and caregiver. I encourage anyone who watches this video, whether you are a warrior, a patient, whether you are a caregiver, whether you are a provider, or whether you are someone with just a huge heart that cares about the outcomes of individuals living with sickle cell disease and about health equity and about making sure that there is care for all individuals from a humanity level. We can talk about this from a disease level, but from a humanity, we all deserve to be cared for. We all deserve to find the pain relief that we need when we are in pain. But even more than all of that, Dr. Nelson called it out. We not just have to deal with the downstream effects of sickle cell disease, we've got to deal with the upstream issues, and that is finding a cure, an accessible cure, not just a cure in one country, a cure that all people can get to. What is happening in Africa with sickle cell disease is still devastating, and it's still more work to be done. And so I encourage all of us to make a difference in some small way, whether it be educating ourselves, whether it be donating to local causes, or whether it be showing compassion for individuals who are living with this. Please continue for all of us to do our part to make this a better, to improve the quality of life for individuals and communities that are affected by sickle cell disease. Once again, our next Sickle Smart Summer will take place on Saturday, July 25th. And then our last Sickle Smart Summer session will be on Saturday, August 22nd. We look forward to everyone being in attendance. Please share widely. You can go to our website starting on Monday and see the recorded version of this video, as well as last month's video, and we'll continue to post previously recorded, as well as the way to sign up for future Sickle Smart Summer sessions. Thank you again. Donate, donate, donate blood and money. There's work to be done. and we appreciate that. I just want to make sure I'm not forgetting anything for those that have asked. Unfortunately, we will not have a walk for sickle cell this year, and we will not have a gala in person this year. We are looking at reimagining what those things will look like in light of COVID and keeping our community safe. We do still want to celebrate with you. This is about celebrating life during Sickle Cell Awareness Month, and so we will keep you updated. Stay tuned to our website and our social media. We can be found at SickleSMN on Facebook, Twitter, Instagram, and then of course our website, SickleSMN.org. Have a wonderful day. We love and appreciate you. Thank you for showing up. Thank you for leaning in. Thank you for using your platform and your privilege. And we'll see you next month.